Hi, my name is Ayesha Kadir. I am a senior humanitarian health advisor at Save the Children and a practicing pediatrician. I'm sorry I can't be with you today, but I've recorded this talk and Nick Spencer will take questions. And I'm also happy to answer questions via email afterwards. I'm going to talk to you today about the impacts of armed conflict on children's health and well, I will briefly give an overview of the scale of the issue and different ways in which armed conflict affects children, but I'll try to build in the various ways that equities are seen in what we know, and also what we know about how conflict and crises drive inequities in children's health and development. I have nothing to disclose. And before we start talking about specifically effects of armed conflict on children's health, I'd like to take a step back and think about armed conflict as a form of violence. It's a form of collective violence, and it has intersections with other forms of violence. There are different kinds of collective violence, like gang violence and narco violence as well, and also interpersonal violence, community and domestic violence. There are also more difficult to study or capture more subtle forms of violence, such as structural violence and economic violence, as well as social arrangements, such as how a child or family's racial background, economic situation, the ethnicity, language determines where they can go to, if they can go to school, where they can go to school, where they can get a job, and even in some very basic circumstances, how they can move around within the place where they live. And so these are different forms of violence that we really need to consider as being related to and intersecting with armed conflict in different, more complex ways. So with that as a start, I'd like to encourage you as you listen to this talk to think about children as active participants in their communities and in their families, who perceive their experiences and have their own thoughts about it, and this affects how they engage with it. And that in turn affects their health outcomes and what happens to them in their future. That this conference is focused on inequities in child health and how to reduce these, it's important to consider how conflict drives inequities. There are differences in child health outcomes even within the same country when you compare peaceful regions with conflict-affected regions. In 2021, over 2/3 of children were living in a country that was experiencing armed conflict, and nearly 450 million were living within 50 kilometers of active combat. And this figure has been increasing since 2000, and then in the last few years, it's actually decreased a little bit. But conflicts have begun to change, or have been changing over the last few decades. They're now more intense and protracted, and the kinds of weapons that are used are different. And these all have impacts in how children's health and development are affected, and also how inequities play out. There are 89, in 2021, there were 89.3 forcibly displaced people. And children are disproportionately likely to be displaced. They account for 41% of forcibly displaced people, but only 30% of the global population. We don't actually have very good figures for unaccompanied or separated children. We know that this trend of children traveling unaccompanied is increasing, and in the period between 2010 and 2019, there were 400,000 children that were known, that were documented and registered somewhere. However, this is thought to be a significant underestimate because a lot of children go under the radar and are not actually formally known to authorities. A lot has been written about the way armed conflict impacts children. This is really since the beginning of humans' use of writing, and it's found in historical accounts and fictional depictions and in religious texts and many different formats, also in paintings and in other art forms. More recently, we have begun to try and scientifically understand what armed conflict does to humans, and also among this to children. However, the data are quite limited, and there are various reasons for this. One of the most important reasons is that routine data collection, where it does exist, it's often disrupted and potentially even destroyed completely in places where conflict is occurring. And also, people are moving around. It's difficult to study carefully, particularly over time, so for longitudinal studies. And this is a particular problem now when conflicts are more protracted. But most of the information we have are from descriptive studies, and most of these are from a single point in time. So it's things like chart reviews and single facility studies and also surveys. Increasingly, there are studies that are using DHS data and mapping that onto to areas where combat is known to have occurred, so a certain definition of conflict based on number of deaths per thousand population, or conflict intensity will be used, and then mapping the DHS data to that to try and understand what we can glean from the kinds of information that are collected in DHS or the multiple index cluster surveys or other survey data. However, this is still somewhat limited, but it has been useful to get a better overall picture. Basic mortality figures are still difficult to confirm. These are based on estimates that are often using multiple sources. They're often not disaggregated by age, and oftentimes, especially when the estimates are including combatants, children are grouped in with the adults. It's very difficult to know what this means for that very, very vulnerable group of children that become involved with armed groups or armed forces, but even on the whole, civilian children as well. Mortality, basic mortality, and of course morbidity is quite difficult to collect and to understand. It's common to divide how conflict affects health by looking at the direct impacts and the indirect impacts. And direct effects refer to the effects from combat activities, whereas indirect effects refers to a host of downstream health effects that result from the conflict and the various social, environmental, and political and structural changes that occur. And these can be long lasting for decades and for multiple generations. You can see here there's a pretty broad list. This is not an exhaustive list. However, I just brought out some of the more prominent and better documented things that children may experience directly from conflict that impact their health. And so experiencing multiple forms of interpersonal violence, witnessing or being subjected to it. Injuries, these can include blast injuries, bullet injuries, motor vehicle crashes when fleeing conflict, buildings falling and crushing, and many other. Illness can occur from depleted uranium weapons, chemical weapons, weapons that contaminate, or combat activities that contaminate the air, the environment. And then disability can occur and not just in terms of losing limbs, but also it can be effective of sight and many organ systems. Children, it's well documented that children are subjected to sexual violence and exploitation, to torture and execution. Children who are associated with armed forces and armed groups are a particular group that have a particular risk profile. The reason they're targeted for recruitment, where they join voluntarily, or forced to join armed forces and armed groups, is because they are still developing and they're easier to mold. Their identity is reshaped. So the process of helping them to demobilize, disarm, and reintegrate is actually seeking to sort of reverse this identity that now has been formed that is linked to the armed group. And children who are associated with armed forces and armed groups have often experienced quite extreme forms of violence and exploitation. They are not only combatants. It's important to understand that the majority of children are who are involved with armed groups are recruited or working as porters and as cooks and as cleaners, as they can be used as combatants, of course, and they can also be used as sex slaves or as human shields. However, it's a whole range of things. It's not just soldiers as such. And then all children who have experienced conflict can experience psychological trauma. And I think it's clear that children are killed by conflict. Now I will review some of the indirect effects grouped into larger groupings. This is not an exhaustive list, but this is meant to give an idea of downstream effects of conflict and how this can affect children's health. Resources and infrastructure are often destroyed during armed conflict. They may be deliberately destroyed. So food supplies, fields may be destroyed, food storage facilities may be destroyed, roads, infrastructure destroyed. And so that leads to food security and lack of access to food. Water and sanitation facilities may also be destroyed. Healthcare facilities are deliberately attacked. Children experiencing armed conflict and also refugee children have very high rates of being out of school, lack of access to education. And a study from Colombia in a recent systematic review suggested that the children who experienced armed conflict during childhood, when they grew up to be adults, they had a lower overall educational attainment. Access to information is extremely important for health outcomes because these children, both from limited education, may have limited ability to read, but also when communication lines are cut or when information, particularly about health and public health and safety, is not available or irregularly available, then these children may be at higher risk. And this is shown in studies to have resulted in higher risk of sexual health problems. There are a number of downstream effects that can cause illness in children. We talked about food insecurity, and that can lead to malnutrition, severe acute malnutrition. Also, there are a variety of infectious diseases as well as non-communicable diseases that these children are prone to. When you look at the major causes of mortality in children in areas where conflict is occurring, it's quite similar to low-income settings that are peaceful. So malaria, diarrhea, pneumonia, and respiratory illnesses and febrile illnesses are major causes of mortality in these populations. Vaccine preventable diseases may recur. Birth complications are a common cause of morbidity and mortality, and this is thought to be related to experience of violence during pregnancy, lack of access to care during pregnancy and during delivery. There are some studies from the Middle East and from Vietnam which have found increased prevalence of birth defects as well as cancer in children and also in the offspring of soldiers who've been in Vietnam and been exposed to Agent Orange. So the cause of birth defects and cancer are thought to be related to toxins either in utero or of the parents, one or both parents. Children who become ill and live in a conflict-affected area have a higher rate of death. Children may be injured by both explosive remnants of war, but also environmental hazards such as unstable buildings or toxic exposures. Landmines still exist throughout the world, and there are also cluster bombs and other unexploded ordnance which are left over and can be present for decades after the conflict has ended. And children have a particular kind of risk in these situations. Children accounted for half of injuries from unexploded ordnance in Afghanistan, Nepal, Eritrea, and Iran in a series of studies. They tend to have different injury profile than adults. So adults will be walking and will step on it without realizing it, and then it will explode, and they tend to have a lower extremity injury. Children more often have upper body injuries because they're out playing and they find it, or they may be going to school, or they may be doing chores, and they pick it up and they may play with it, or they have it in their hand, and then it explodes and injures their upper body and head and neck. And these children also have a higher risk of mortality because of the location, the nature of their injuries. There's a study about availability of weapons from Croatia, which is really quite striking. The study found that during the Yugoslav Civil War, children had the rate of homicide and suicide using a weapon increased more than threefold, and the rate of unintentional injury from weapons in children increased more than sixfold during the war compared with the pre-war levels. And they followed this trend after the war, and it slowly decreased with time to the pre-war level. So the learning point from that is that the availability of weapons, and in particular small weapons, is related to weapon-related injury in children, both unintentional and intentional. Thinking about armed conflict as a kind of childhood adversity, we don't have a lot of data to support this yet. It seems sort of obvious on the one hand, but the studies are not so strong and not quite there yet. This diagram is a rather complex diagram looking at extreme weather-driven disasters as a social determinant of health and a childhood adversity. And it's complex because it looks at both the biology of the child, the biophysiology of the child, stress physiology, and then also external factors around the child that can both protect and harm. I think this is a really important perspective to consider, and it lends itself well to looking at armed conflict and thinking of that as a social determinant and as an adverse childhood experience. There have been some studies from World War II, from a birth cohort in Finland of children who were separated from their parents for a period during World War II. And these studies, a series of studies, has found altered stress physiology in children who were separated from the parents for a period, and this was dependent on the age of separation. Similarly, boys had lower intelligence scores, boys who had been separated, and this was more prominently seen in children who were separated at a younger age and for longer periods of time. Girls in the cohort had earlier onset menarche. Similarly, there was a more recent study in Israel that looked at children who were exposed to rocket attacks and whose mothers had mental health, psychological trauma relating to this, and they found altered stress physiology by means of cortisol, blunted cortisol, lower baseline levels, and blunted stress response, and this was independently related to the maternal mental health. Other things to consider are more pervasive things that affect children's health and that perhaps are more difficult to draw direct causal links, but certainly have an impact on the child's health and long-term outcomes. And this has to do with changes in social arrangements, in particular the role of children. So children may become caregivers for ill or disabled family members. They may become the head of the household. They may take on various adult responsibilities, and they may also take on more adult behavior, such as increased or earlier sexual debut is well described. Children may also become breadwinners for their family, and child labor is contributing both to children being out of school, but these children are often working in places with hard labor and with fewer safety precautions, so they're at high risk for injury in their workplace. The diagram or the graph on the right shows a dramatic increase in child marriage among Syrian refugees living in Lebanon. So in 2009, before the war, there was 6.6% of 15 to 17-year-olds were married. And in 2016, 1/4 of 15 to 17-year-old Syrian refugees were married. Social marginalization has an important impact on children's opportunities, both in terms of access to their basic needs, but also in terms of their ability to thrive and their opportunities for their future. Particular vulnerable groups are displaced children, so refugee and internally displaced children, children who are born of rape, children who've been detained for whatever reason, incarcerated for any reason, and children who have been associated with armed forces and armed groups. So these are particularly vulnerable groups. There have been a number of studies from around the world looking at relationship of physical abuse and exposure to armed conflict. Studies in Timor-Leste, Uganda, and Lebanon have found that caregivers who suffer from stress or have mental health distress related to armed conflict report higher rates of child abuse. And in the study in Uganda, they also asked children, and children also corroborated this and reported higher levels of physical abuse relating to the caregiver exposure. The Ugandan study found that, or suggested that war exposure and subsequent trauma were mediating factors for violence against children. There have been a number of studies looking at the children of US military personnel. These children are well known to have a higher risk of child abuse and neglect during the period of parental deployment as well as after return. And this is so much so that the military has established trauma-informed care programs to try and identify children at risk and to protect and promote child health. These children, however, also experience violence in other places outside of the home. So they are more likely to be bullied in school, they're more likely to carry a weapon, and they're also known to have higher rates of substance abuse compared with the children of civilians. Mortality is a big question mark. There are quite a lot of challenges to assess mortality. This is especially because children tend to be lumped into the general statistics. There's really a paucity of age disaggregated data, and the sources of the data are often questionable. There are some studies that really especially are looking at downstream sort of indirect impacts of conflict on children's health. And what they found is that the major causes of child mortality in populations affected by conflict are similar to those in low and middle income settings where resources are limited and in vulnerable populations. So this is pneumonia, diarrhea, measles, malaria, and malnutrition. The reports on trauma mortality are very wide-ranging and especially high with neurosurgical patients, but there are no figures for mortality or disability after hospital discharge. And there's a now not quite so recent a systematic review that was published in 2019 where some studies did look at, in fact, one study pooled data from 37 data sets between 1985 and 2001, and it had some interesting findings. They found that the relative risk of dying during periods of conflict was higher for children that were over 5 years of age, and that in some countries, being under 5 was protective. And this suggests or highlights the nuances that in the ways that conflict affects child health and development and mortality, and also that there are context-specific factors that lead to conflict-associated mortality, which is different for children at different stages of their childhood. And there are some studies that suggest maternal education may be protective, and also there are studies that look at displacement and have found differential mortality for children displaced for different reasons, and that children who were displaced due to conflict in Angola, for example, carried a higher rate of of mortality within the first year after migration compared with children who migrated for other reasons. What we don't know may be as important or more important than what we do know. The geography of our knowledge, as I will show you in the next slide, is both limited and also quite striking in how some areas geographically are prioritized while others are not. And the implication for this is that some children's lives matter while others do not. The ways we measure and document it means that we look with a kind of telescopic view. We don't capture the bigger picture. We don't have an understanding of the long-term effects or what this actually means for children as they go through their lives. And there are also not many studies that compare different contexts. So we don't really understand how the context of conflict and also the existing conditions that children were living in, and also what happens over time, how all of this context can impact children's health, either negatively or positively. And finally, we have a very limited understanding of what interventions work to protect and promote the health, development, and well-being of children affected by armed conflict. And I'm working with colleagues on a systematic review of the recent literature on this subject at the moment. So hopefully I'll have a little bit more information to share with you about this later on this year. This is a map which shows the number of countries 1990 to 2016 where armed conflict was occurring. The yellow and pink and red countries are where a conflict occurred in that period. And the pink and red countries it's a gradient to show the countries where studies were done. So there's a lot of yellow on that map where there are a lot of children whose health in relation to conflict has not even been looked at. Briefly summarize, there are marked disparities in health and social outcomes for children who are in conflict-affected areas compared with stable and peaceful areas, and this happens even within a single country. And the evidence for this is from UN agencies, from non-governmental agencies, and also from now these more recent studies that are mapping DHS data to specifically areas where conflict has occurred, and comparing that with stable areas within a country or across multiple countries. And also the way conflict is occurring and the situation for populations that are affected by conflicts is changing, especially with protracted and bloodier conflicts. And so what this means for children will also be changing. And looking at what happened 20 years ago is slowly becoming quite a bit less relevant, and we need to understand really now what's happening and gain the biggest gap perhaps is what happens for a child who is affected here and now in some way, either directly or indirectly, and then ongoing direct impacts, and then what happens to this child as they go through their life, so the medium and long-term impacts, what this means for populations of children who are growing up today in Afghanistan, in Yemen, in the Democratic Republic of Congo, who are experiencing multiple adversity and lots of health risks as well, acute health risks, and then the conflict on top of it. That is not well understood. So we have a long way to go, but one step at a time. I'm really pleased that that this is a focus within this conference, and I look forward to following what comes from this. Thank you very much for your time. I hope you've enjoyed this and that it's helpful. I'd be happy to answer any questions as they arise.